Assalamu alaikum, and thank you very much for inviting me today to for this quiz. Um, Interstitial lung disease, HRCT in general, is a specialty in radiology, which I think very few people in Pakistan actually have a very, very good command over. When I finished my residency in 2014, I don't think I was trained too well on HRCT purely because where I was trained, they did not have that. I mean, they reported well, but they didn't have the expertise. So they would often also have internal discussions, and it was always a bit of confusion. So when I graduated, I automatically had a block against HRCT. कि ये तो बहुत मुश्किल है, and I don't know when I'll ever be able to learn it. But coming to Indus Hospital, and over the years, we have bought books over here because we have a lot of patients who present to us with ILDs, and working with Dr. Sohail and Dr. Saima, and then the radiology team together, I think we've all learned together over the years, and it's still difficult, but together we collaborate and we come up with diagnosis and try and help patients. So I'll just show you a few cases. It's going to be short. Just to have an idea कि आप लोगों ने सब कुछ तो देख लिया आज. Everyone has given individual talks on sarcoid, hypersensitivity, pneumonitis. So you know all the individual features of each disease. So I've just mixed up the cases and we can just go through them to get an idea about how much you may have picked up today. So for case one, this is a 39-year-old female with past history of COVID. She had a non-productive cough she presented with non-productive cough for 4 months, worsening shortness of breath, and went from MMRC 3 to 4. So as you know, the baseline would obviously be a chest x-ray. So can someone just tell me what they see in it? I do see my residents, but they know the cases. And they've seen all these cases. So if anyone would like to try from the audience, any pulmonology residents? So we wouldn't use the word inflammations, but yes, there is blunting of the right CP angle, and there is some non-homogeneous opacity at the right lung base, and on the left also we see some patchy non-homogeneous shadowing. So on this X-ray alone, it's hard to make a diagnosis. So an HRCT was done. And would anyone like to attempt this? So we have axial and coronal views of an HRCT in the lung window. Would anyone like to try? Okay, so if I were to ask you, do you think this is an interstitial lung disease? It could be. Okay, so if it could be, what do you think do you think it's UIP? Right, it's not. Do you think it's NSIP? No, it's not. What else? Right. So what would you expect? Good. So this is organizing pneumonia, in which you can see that there are subpleural triangular consolidations seen on the right, along with some pleural effusion. Let me try and get a marker here. A laser pointer, right. So these are the subpleural consolidations here in the lower lobes, over here in the mid-lung zone, and then you have one over here in the upper lobe. And then on the left, you can see that there is patchy ground glass on the coronal sections. They're visualized well here, posteriorly, and then anteriorly in the upper lobe as well. So this was a case of cryptogenic organizing pneumonia. And this patient had recovered from COVID 6 months back. So there is always a struggle that is it post-COVID? Is it organizing pneumonia? Then you have to get serial examinations done before you can actually label it. But this was not typical post-COVID fibrosis, which we see, which is usually bilateral, more along the bases, and it has a very typical appearance. So these triangular consolidations went more towards cryptogenic organizing pneumonia. So these are the features that we would see in COPS. So in our case, we saw the ground glass opacities as well as the parenchymal consolidation. And then there was also a fibrotic pattern. So that further confirms that that was indeed COP. So for our next case, we have a 44-year-old female, known case of interstitial lung disease, severe restriction on PFTs with a FVC of 44%. She was hypertensive and obese with worsening shortness of breath and went from MMRC 3 to 4. Once again, baseline, you would get a chest X-ray done. So would anyone like to comment on the chest X-ray? So yes, so we see that both lung fields actually look really dirty. They don't look clear at all, but they're like ill-defined, patchy infiltrates, which are pretty much involving both of the lung fields, and it's non-homogeneous, but you can't really tell whether it's central and it's peripheral. So in such a case, you would require an HRCT to further see what the parenchymal, how the extent of the parenchymal distortion. So this is the CT that was done, and you can see that there is a lot of lots of parenchymal changes in this. So would anyone like to attempt? So when you see an HRCT for interstitial lung disease, you should look for fibrosis. And most importantly, you should see whether there's what area of the lung is it affecting. So this patient came to the hospital with after undergoing treatment for 4 years for a known ILD. So I want you to just come up with a diagnosis, and then I'll tell you what she was being treated for and before she was shifted here. So does everyone agree that there is fibrosis? Yes. There's bronchiectasis, there's fibrosis, there's architectural distortion, it is peripheral. Involving the upper and middle lobes. So who thinks this is NSIP? So this patient was treated as NSIP before coming here. And then we had a repeat radiology, and it just didn't fit in the radiological picture. So this is actually a case of a chronic hypersensitivity pneumonitis. So it's CHP. So even though clinically there was such a strong suspicion, and it's very easy to label things as NSIP, but you really have to look at the zonal distribution. And that is why I put up these coronal images, just to give you an idea about how most of the pathology is based in the upper and mid lung zones, and the bases are relatively spared, relatively. So this is a case of chronic hypersensitivity pneumonitis. Our third case is of a 47-year-old female with pain in small joints of hands for 4 years, with morning stiffness, rash for 1.5 weeks, and occasional fever. As well, I don't know if as a pulmonologist if you can diagnose this, but generally in our books, when you get this picture, when you get this clinical picture, you have a diagnosis in mind. RA. Right. And Dr. Saima already told us what it's most associated with. UIP. So certain times we can get blinded, and I do that. If I see RA, I just assume it's going to be a UIP even before I open the scan. So chest X-ray was done. Right. So there are bilateral infiltrates. They're more marked in the subpleural region on the left. However, you also see a lot of reticular shadowing on the right. So once again, this patient underwent an HRCT. And would anyone describe this now? And mostly involved in the lower. Okay, so in this coronal, this is basically the posterior. So this is the basilar part. The point of this is to show you that this is basilar. So it's all basilar. And then as you come anteriorly, it becomes clearer. And this sagittal is just to show you that the upper and mid zones are spared. And here you have all this architectural distortion. What would you call this, all this happening here? This is honeycombing. So a UIP, the main difference between UIP and NSIP is that you have more honeycombing in UIP as opposed to NSIP, and in NSIP, you'll have more ground loss and less honeycombing. However, honeycombing is also seen in NSIP in the later stages. But in such a case where you don't see any ground loss and just peripheral subpleural honeycombing more in the bases, you'd think of UIP. And of course, the history is also a huge indicator. So for our fourth case, we have a 54-year-old female with shortness of breath for 5 years, MMRC1 with orthopnea, and cough with minimum sputum. Once again, chest x-ray done, which is actually not as bad as the previous ones, but does anyone see changes in it? So you can see that the right, middle, and the lower lung zones don't look as clean as the upper zone. So there you see some ill-defined reticular nodular shadowing in the bilateral mid and lower lung zones. So this gives you this is an alarm for let's get an HRCT to see what is going on in the parenchyma. And then this is a scan from 2021 of this patient. So can everyone appreciate the ground loss here in the bases? Yeah, so you can see that as we go up, it becomes less over here. And then once again, I put a sagittal up just so that you can see that there's all this ground loss up to here. And then generally this is clear. So this is where the haziness is. If this patient is to present you for the first time, this is a very non-specific finding. You could get this in if there's basilar vascular congestion, or it could be due to it could even be pulmonary edema, it could be infection. So on this scan alone, you would not label this as anything. This is not typical for any ILD for a first scan. But if you have a very strong suspicion that the patient has some interstitial lung disease, you would think of NSIP, right? But this scan alone is not enough to label it. A follow-up was done 2 years later of the same patient because it was on the fence of is it infection, is it an ILD, but because there was a strong clinical suspicion, the patient was followed up in clinic. When she worsened, this scan was done, and we can see that the changes have progressed. They're in exactly the same place, only that they're more prominent. So this solidifies the fact that this is NSIP. And just so you know, this patient was treated as NSIP from 2021 because of the clinical suspicion and followed up in the clinic. And when she worsened, a repeat CT was done, and the clinical suspicion was confirmed that it is indeed NSIP. So this is just to show you that this is the 2021 base and this is 2023 taken at the same level to show that there is worsening of the disease. So this is progressed NSIP, and these are very early non-specific changes. So often enough, these findings can get missed on a patient if you don't have a strong clinical suspicion. Then this is a case of an 80-year-old male who had history of smoking but quit 5 years back, productive cough for 20 days, shortness of breath on minimal exertion, weight loss, and undocumented fever. This is the X-ray. So it's pretty bad. It's pretty bad. Would anyone like to, can one of my residents please just describe it? Amit, please. And the more on the right side, these are when there's a area of virus circulation, noted in the left mid zone. So what he's basically saying is that you have all this reticular shadowing infiltrates here, diffuse in the right lung field. There's preservation of the lung volumes. And on the left also, we see some patchy infiltrates. And then you see this nodule here in the left lung field. So a CT chest was done. This patient basically had a very strong clinical suspicion of TB, sent to us to rule out TB. No one suspected anything else. So this is the HRCT, in which we can see that most of the changes are in the upper and mid zones, relative sparing of the lower lung zones. That means you can take out UIP and NSIP, okay? Then you see diffuse emphysematous changes in both lung fields, which correlates with the patient's history of smoking. That's why the lungs are hyperinflated, and this is COPD. However, what we do see is what is of more concern is that all of this interlobular septal thickening, and it's giving a crazy paving appearance in which you can actually see the outlining of the secondary lobules here. This is all crazy paving that we see over here and over here, especially here. So does anyone have any idea when we say crazy paving? Because you get a list of differentials in your head. So I would also want all of you to focus over here that on the left, it's essentially clear. It's clear, and you have this solitary pulmonary spiculated nodule. So this is a case of CA lung with lymphangitis carcinomatosis, yeah. Which is also comes under. So patient came with a different clinical suspicion, left with a whole different diagnosis. So these are pretty much the cases that I brought with me, because I figured in 15 minutes, this is as much as we can do. But I would encourage everybody, wherever they work with the pulmonologist alongside and come up with a diagnosis together, because radiology itself cannot diagnose anything. Everything is not specific. You need clinical expertise for everything. Okay, thank you.